Morning, everyone. Thank you very much for coming here to listen to our presentation. This is our third Data Bytes presentation, and today we'll be talking about septicemia or sepsis in DD population. I just wanted to let you all know that our first Data Bytes presentation, which was about pneumonia in DD population, has been approved for Ohio Board of Nursing CE credit. So any of you who are interested in getting CE credits can watch the presentation that's posted on our YouTube page and take a test following that. And if you get at least 80% score, you are eligible to get CE credit of 1 hour. We are also working on getting approval for all of our presentations. So I think the second and the third one will be submitted for approval in a few days. So if it's approved, then these presentations will also be offered for Ohio Board of Nursing CE credits. So our presentation today is divided into two parts. The first part, which is entitled as Hospitalizations associated with septicemia or sepsis in intellectually or developmentally disabled individuals served by Ohio DODD, will be presented by me. And the second part, which is about predictors of septicemia or sepsis in DD individuals, will be presented by Abby. So to begin with, why are we interested in septicemia or sepsis in our population? This graph shows the top 15 most frequent diagnosis-related groups associated with hospitalizations in DD population in calendar year 2015. You can see that the diagnosis-related group septicemia or sepsis with major complications and comorbidities was the second most common DRG in 2015. And there was another DRG called septicemia or sepsis without major complications and comorbidities, which was one of the top 15 DRGs in 2015. So actually, if you add the number of people that fell under these two DRGs, septicemia or sepsis will be the most frequent diagnosis-related groups assigned to DD individuals who were hospitalized in calendar year 2015. So this DRG was the most frequent DRG in our population. Not only most frequent, but this DRG also was one of the most costly diagnosis-related groups in our population. So we wanted to know more about septicemia and sepsis in our population, so we did this study. So the objective of this study was to quantify the admission rate and cost associated with septicemia or sepsis admissions in DD population. And the second objective was to come up with strategies to reduce incidence of septicemia or sepsis and make the lives of DD individuals better. So what's the difference between septicemia and sepsis? Septicemia is actually the presence of multiplying pathogen or the toxin in our blood, and usually the pathogens are bacteria, while sepsis is the inflammatory response of our body as a result of septicemia. Sepsis always starts as a local infection, for example, pneumonia, infection of wound, or urinary tract infections. And if we go back to the slide here, you can see that a lot of DD individuals had these local infections like pneumonia, respiratory infections, and you can see UTI, kidney and urinary tract infections. Those local infections were very common in our population. So sepsis can lead to septic shock. It can cause tissue damage, organ failure, and finally death. According to CDC, more than 1.5 million people get sepsis each year in the United States. about 250,000 Americans die from sepsis each year, and 1 in 3 patients who die in a hospital have sepsis. So this is an important medical condition in the general population as well, not just our DD population. This slide just shows the signs and symptoms of sepsis. If a person is known to have a local infection, and if you see these symptoms like shortness of breath, high heart rate, confusion or disorientation, sweaty skin, extreme pain or discomfort, shivering, fever or very cold, then the person is likely to have sepsis. So for the purpose of this study, the population that we used was those living in an ICF or on a waiver as of December 2015 in our DODD data warehouse. Then we pulled claims data associated with septicemia or sepsis hospitalization for our population from QDSs, and the claims data was limited to those that incurred in calendar year 2015. We matched the individuals between DODD data warehouse and Medicaid data warehouse using Medicaid number or Social Security number. And then we used diagnosis related group to identify patients with septicemia or sepsis. We also compared the incidence rates of septicemia or sepsis between DD population and Ohio's general Medicaid population. So our study population had a total of 42,384 individuals, and I want to repeat that these individuals are those who lived in an ICF or were on a waiver in calendar as of December 2015. And 85% of our population were on waiver and 15% in an ICF. Our population had more males than females. 59% were male and 41% were female. So this slide shows you the admission rate of septicemia or sepsis per 1,000 population, DD versus general. You can see that the admission rate in DD population is about 8 times higher than Ohio's general Medicaid population. And by general Medicaid population, we mean everyone in the Medicaid system except DD individuals. So we excluded DD individuals from that population. Admission rate is higher in DD population, and we were also interested in knowing the cost per person, DD versus general. And the next slide shows you that. It's interesting that although the admission rate is higher in DD population, the cost per person is higher for general Medicaid population than DD population. In general Medicaid population, it was $18,694 per person, and in DD population, it's $17,419 per person. So this slide shows you the admission rate by gender. The admission rate per 1,000 was slightly higher in females compared to males, 16.9 per 1,000 person in females and 15.8 per 1,000 in males. So we were also interested in knowing the admission rate by admission rate for ICF and waiver people. Admission rate is higher for ICF people compared to waiver people. You can see that for ICF, it was 14.3 per 1,000, and for waiver, it's 11.7 per 1,000. Although the admission rate for ICF individuals is higher, you can see that the cost per person is lower for ICF people compared to waiver people. So since the cost per person was higher for waiver people, we were interested in looking at the length of stay, average length of stay for these two populations. I mean, the average length of stay in hospital for these populations. And you can see that there's not much difference between the average number of days in hospital for ICF and waiver population. For ICF, it was 6.6 days, and for waiver, it was 6.8 days. So this slide shows you the admission rate of septicemia or sepsis per 1,000 DD population by age group. You can see that the rate is higher for 0 to 2 age group and for 65 plus age group compared to other age groups. And this makes sense because for the age group 0 to 2, the immune system is not completely developed, so they are not able to fight infections as efficiently as higher age group people. Also, for 65 plus, your immune system starts getting weaker and weaker as age progresses. So it could be that their immune system is weaker to fight infections. So the rates are higher here. So this slide shows you the clinical conditions that were present among DD individuals who were hospitalized for septicemia or sepsis in calendar year 2015. You can see that the first two bars represent the clinical condition pneumonia. The first one is for bacterial, and the second one is for those pneumonia that could not be classified anywhere else. If you add those together, like 48% of individuals who were hospitalized for septicemia also had pneumonia. And the other clinical conditions present among those hospitalized people were diabetes, cerebral palsy, you can see neurological discord, infections like urinary tract infections, skin infections, pressure ulcers, and some injuries. So this slide shows you the rates of septicemia or sepsis admissions per 1,000 DD population by county, and the counties with darker colors are those with higher rates, and those with lighter colors have lower rates of admissions. There are some counties like you can see on the southeast that have higher rates, and there are some on the top. So the conclusion that we can make from this analysis is that admission rate of septicemia or sepsis is higher in DD population compared to the general population. As mentioned earlier, you can see that in DD population it was 16.3 per thousand. In general Ohio Medicaid population, it was 2 per thousand. And according to CDC's National Center for Health Statistics, the admission rate for septicemia or sepsis in 2008 was 3.8. So the admission rate in our population is higher compared to those two rates. And just a second. Yes. Also, we saw that the admission rate was higher for age group 0 to 2 and 65 plus. So special care should be taken to prevent sepsis in this population. Although rate of admission is higher in ICF population, cost per person is higher for waiver population. So this indicates that we need to. So this indicates that our control efforts should be focused in both waiver and ICF population. So next Abby is going to present about predictors of septicemia among Ohioans with developmental disabilities and Ohio Medicaid recipients. Yes, yeah, I can. Yeah, if you have any questions, you can type it, or you can just ask me here. Any questions regarding the first part of this presentation? Yeah.
Do you know why it was higher within the ICF versus the waiver?
Yeah, I think that in our ICF, like people are more sicker compared to the waiver population. Like a lot of people with pneumonias and pressure ulcers and like skin infections are in ICF compared to waiver. And once you have those local infections, you are more likely to have septicemia or sepsis.
Can I add something?
Yes.
The waivers included not just the IO waiver, which would be probably more comparable to the ICF population, but it includes like level 1 waivers. So people that really only require a minimal amount of care or are living at home with family, and so there's a much broader amount of health needs.
Yes.
Did you look at, or are you planning on looking at the change over time? Is this getting better or worse?
We have not looked at change over time yet, but we are planning to like track the incidence rates of septicemia for like waiver homes and ICF that now, so that they have higher rates. Yeah.
Okay, we're gonna switch gears just a little bit and move on to predictors. So this part of the analysis addresses two main research questions. So we want to know if having a developmental disability or having developmental disability status is a predictor of septicemia in Ohio, and do known risk factors of septicemia play a role in the relationship between developmental disabilities and septicemia. And so to address these, I use logistic regression analysis to determine if the following are significant predictors of septicemia. So I looked at age, sex, race, region of residence in Ohio, which I use the Ohio tourism website to identify the 5 main regions being Northwest, Northeast, Southwest, Southeast, and Central. And then it's having a developmental disability, having a diagnosis of a respiratory disease, having a catheter, or having a ventilator. And just a few other notes, I divided race into 3 categories, so it's either white, black, or other. And I originally had region as 1 variable, but it got split into 5 different variables. So either yes, you're in this region, or no, you're in that region. And so the process of gathering this data was very similar to what RT did, with a few differences. So the sample size ended up being around 109,000 people with DD people and Medicaid people. So it was split about 70-40 DD and Medicaid. To get the 40,000 Medicaid sample, I used random sampling to identify that, and that will play a role later in the analysis. And so the DD population includes waiver and ICF individuals, and we basis the diagnosis of sepsis based on primary diagnosis and diagnosis-related groups in Medicaid, and all this data is from 2014. And so this sampling and analysis design is a little bit complex, so I'll try to explain it out the best that I can, and please stop me if there's questions. So the first step that I did a univariable analysis of each covariate. So I put in a regression model sepsis and each covariate individually to decide if this was a significant covariate. So I set it at a pretty low and easy cut point of 0.2. So if the variable had a chi-square p-value of 0.2 or less, I decided to keep it in the model. If not, I set it aside. And once I made my final model, I added things that I set aside back in to see if it made a difference. So here's the first couple of variables. So we see that age, sex, and race were all significant in this analysis, so I decided to keep them into the model. You see the different regions there with their associated p-values. There's a lot more variability there. And Southeast ended up being not significant at a level of 0.2, so I set it aside. And then you see that DD, respiratory, catheter, and ventilators were all significant, so I put them in the model. Before moving on to interactions, I then did a multivariate model where everything from here that says keep, I put into a logistic regression model and did backward selection to see if it was significant then. And so I threw out a few of the variables there with a very tight cut point of 0.01. So at 99% confidence, I determined if it should be considered in the model. And so from that, I threw out a couple of the regions, and I ended up throwing out sex and race. And in the middle of this analysis, I assessed for confounding. So if the coefficients changed greater than 20%, I assumed that there was confounding. But luckily and thankfully, there was none. So that's great. But I did test for interactions. So I tested 20 potential interactions. So this is saying, does one covariate interact with another covariate and change what sepsis looks like together? And so from these 20 potential interactions, only one proved to be significant, and that was between respiratory and age squared. So I also did an analysis to look at, in this model, what is the best way to represent age? And so when you look at the distribution of Medicaid recipients and of people served by DODD, we have a lot more kids than older people. So it's a very sharp slope down when you look at that graphically. And because of that, to fit well into the model, it was best to look at it quadratically, which is complicated. And don't ask me questions on that, because I will tell you the wrong thing for sure. But it is what it is. And so changing it to quadratic just helps that distribution be a little bit more level. So you'll see later I noted this interaction as RA, meaning respiratory and age. And so in the model, the interaction is significant with the wall test p-value of 0.004, which is really good. So from this, I made some conclusions. So you'll see here that I have explained out some odds ratios. Because of the complex sampling, I was not able to do straight out predicting because I used a random sample in part of the population. And so all these odds ratios control for everything else that's in the model. So I didn't write that on all that because it'd be a lot of words and a lot of me repeating myself. But so the things that we can conclude from this is that the odds of sepsis for an individual with a developmental disability is 1.71 times that of an individual without a developmental disability. And that follows up with what Archie said, where we saw in the graphs that people with a developmental disability had higher risk, and they also have significantly higher odds.
I should probably restate it again, because Archie's, her was like 8 times as high, but she wasn't controlling for anything.
Yeah. Right.
And so hers would have, the likelihood, the fact that our folks are so much likelier to have pneumonia in the first place and things like that, whereas Abby's has controlled for that, and so just having the developmental disability alone still makes you at a higher risk.
Yeah, so this is a lot more conservative of a statistic, but with both statistics together, both being significant and higher, that speaks volumes. We also see a huge number next, that the odds of sepsis for an individual with a catheter is 42.17 times that of an individual without a catheter, and we don't see odds that high a lot. That's very high. Next, we see that the odds of sepsis for an individual living in northeastern Ohio is 1.48 times that of an individual living in any other region. And so Archie showed us that pink map earlier. And if you refer back to it in the, where are we at? You can go back. In the northeast, there was a lot more dark counties represented there. And we see a very similar story for southwestern Ohio, with 1.6 times the odds of an individual living in any other region. So again, in that map, we saw a lot of dark counties in that corner. And based on that interaction, we saw that age modifies the relationship between sepsis and respiratory infection. So across age, we see a trend in sepsis, and this is modified by if you have a respiratory infection or not. So as age increases, the rate of sepsis also increases, but it looks differently for someone with a respiratory infection, such as pneumonia, versus someone who does not.
So what can be done to prevent septicemia or sepsis infections? If you are a healthcare professional working with DD individuals, you can be alert to the signs and symptoms of sepsis and get the person treated as soon as possible, because and if you suspect sepsis, then you should get the person treated as soon as possible, because sepsis is a medical emergency and time matters there. You can also prevent infections by following infection control practices. Ensure that your patients receive recommended vaccines. And then you can also educate your patients and families about preventing infections, taking good care of their chronic conditions, and to follow good hygiene practices like hand washing, keeping their cuts and wounds clean. Can I have that right here? Oops, sorry.
Maybe.
So this slide gives you a link to CDC's web page where you can go and find very nice, useful information about how to prevent sepsis in a population. With this, I'd like to thank everyone for coming here today and all of you who are listening to this webinar. If you have any questions, feel free to ask.
I have one question. In one of the slides, it showed the southeastern portion being particularly high. When we controlled, that all kind of went away. And it became the northeast and the southwest. Any reason, or do you know why the southeastern portion of the state had a high incidence?
There's a few different reasons. Also in that map, there's a lot. So there's a few counties with high rates.
Right.
But there's also a lot of counties with 0 rates, and you also have a lot smaller population. So when you think of northeastern Ohio, you have Cleveland with a huge population, and you think of southwestern, you have Cincinnati with a high population. So when you're taking population size into account, that impacts the rates a little bit. So seeing a high rate in a higher population means a little bit different, even after adjusting, than it does in a smaller.
Are there any seasonal, not necessarily seasonal, but like special events, like a particularly cold winter or something that would cause more pneumonia that might lead to more sepsis? Or are there any like major events like that that you would be aware of, or is it kind of with sepsis in particular, it just kind of occurs normally, or I guess consistently over the years?
We haven't looked at the season, like in this study, we only looked at like calendar year 2015, like January through December. I think since we have not done that study, like looking at the seasons, but I think that people's if people have pneumonia, it gets aggravated during winter, so it could be that. But still, I haven't looked at over seasons, but it could be that in winters the admission rates are higher, but we'll have to look into the data. I'm just assuming that it's higher because in winters the pneumonia, like I think pneumonia, people get more affected with that condition and other, yeah. But at the same time, like I don't know if during winters if you have like sores, like during summers it will get worsened. So we'll have to look into that by analyzing data actually.
Those regions seem pretty large. Have you added, do you have the detail to get to a smaller grouping, perhaps service providers or something?
Yeah, that's definitely possible. The problem that we run into, it's a lot easier for more simplistic analysis to do it in smaller. Had I done smaller in the logistic regression, because we only have a case size of 700 to 800, you have to be careful about how many factors you slide in there. So it's almost like if I had a pizza and we shared it for this room, the more people in this room, the less of an impact you're going to make on that pizza. So the more things that we put into the regression pizza, the different their impact looks.
We're doing some other analyses related to septicemia down to the ICF building level and down to the waiver provider level. But because this is a public presentation, we also have information down to the reporting county level. We're not trying to call people out or on high rates in a public forum. But we are looking at that sort of ourselves. This was more rolled up to a higher level just to give a general idea.
Yes.
Do you consider any, have you ever tried to look into maybe, types of medications that would, maybe like you did with the vent and the catheter, maybe certain types of medication that reacts to the body in that way to maybe, strengthen the instances of sepsis?
We haven't
Like
looked
a
at
built-up?
it.
Okay.
Yeah.
Just curious.
Yeah. Anything else?
And all of your data on sepsis is folks admitted to the hospital with sepsis versus getting sepsis once they were in the hospital, correct?
Yeah, so the first part was about admissions. So whoever was admitted with sepsis and were assigned a diagnosis-related group of that sepsis or septicemia. It's not tough. Not
to that before they were discharged, though.
Sorry?
They could have been admitted with pneumonia, though, and it could have turned into sepsis. And if the billing qualified them for the level of dollars that would go along with sepsis, they would be included here, I believe.
Yeah, that's true.
This is, so I thought if they acquired sepsis in a hospital, that Medicaid would not pay for that. So would that keep it out of the claims, or are there cases where you could acquire sepsis in a hospital and Medicaid would pay for it?
So our data had those individuals for whom Medicaid did not pay for, because we had rows where the inpatient cost was zero. So
Gotcha.
they could have, like, those cases could have been hospital acquired, like hospital acquired
Gotcha.
cases. Yeah.
Okay, that's helpful.
If you don't have any questions, we would like to thank you again for coming here and listening to this presentation. Yeah, thank you very much.
Thank you.